Alrighty, so the Grateful Dead are on in the background. Hopefully it's not too distracting. Uh, we're going to talk about antimicrobials. These essentially are the same things as antibiotics, but because some of the um, small organisms that we try to kill are animals, and therefore are not bacteria, antibiotics would not actually apply to them. So let's start with a case. This will be good for those of you that are thinking acute care. The challenge with this case is that for some people, it really just isn't a challenge. 66-year-old woman, she's got a red open area on her foot. Husband died 6 months ago. She's been diabetic for a while. What should we do? Well, we should put her on antibiotics, of course. Well, and what antibiotic should we be? Well, the first thought for most of us is whatever antibiotic we've seen other people put her on for the past 10 years. Ceftriaxone, that kind of an antibiotic. Maybe Levaquin. Well, unfortunately, as we move into more advanced roles, we can't really just go by what we've seen done. We really have to kind of understand what's going on. So let's think about this. Another example, this is strep throat. You got a 4-year-old boy, 2-day history of sore throat. Brother went to the walk-in. They started him on antibiotics. Joey is positive for group A beta hemolytic strep. He is allergic to penicillin though. So that's one of the problems is now all of a sudden we can't use what we were expecting to use and we have to use something different. And so the allergy was actually a mild rash at 4 months old when he started on amoxicillin for an acute otitis media. Is this a real allergy? Would you be comfortable starting him on a penicillin type medicine anyways? Again, very difficult decisions. So just to reiterate, we'll talk about it more in class, but you will be doing some case presentations. And so in those case presentations, you need to develop your clinical scenario. You'll have to extrapolate some information and come up with some assumptions. You'll have to talk about whatever the medication choice would be and why you chose that thing and what the pharmacodynamics are. A little bit of a discussion of kinetics, interactions, and adverse reactions for 20%. Teaching plan, and again, specifically thinking of the provider role level teaching plan. What do you really need to tell somebody in a quick interaction, either in the office or in some other similar setting? So we'll grade also on format and also on technology. Many people will choose to do this as a YouTube presentation, which is fine, but we'll talk more about this in class. So in regards to Joey, just to go back to some basics, you do need to do symptom analysis before you can decide on what antibiotic you're going to use or what medication you're going to use. You need to know exactly what's going on. So OPQRSTU is a good way to do your history of present illness. O is are other people sick? P is provocative palliative. Q is quality quantity. R is region radiation recurrence. S is severity and other symptoms. T is timing and temporality. Temporality, of course, is what time of day something happens. And U was added by some colleagues at Indiana University. And basically that's asking the patient, well, what do you think is going on? So how do you make the diagnosis? Is a positive rapid strep enough? Well, are there people that have positive rapid streps all the time? Does it completely rule out other possibilities? Is it possible to have group A, B to hemolytic strep and mono at the same time? Well, the answer to that is yes. How often does that happen? Maybe as much as 7 or 8% of the time. So we need to be really thinking about whether or not there's two things going on or whether there's just one. Drug of choice for strep is you're going to check the Sanford guide. You're going to see that it's probably penicillin for adults and amoxicillin for children. What other references can you use? Great things to be thinking about whenever you're trying to make these kinds of decisions. All right, let's go back to Mary Pat. Again, your decision making has to be more involved than let's just give her an antibiotic. It's easy to say, oh, I've seen this done and that's why I'm going to do it. So you need to know what the drug of choice is. So the Sanford Guide will give you that. Up to Date will give you that. In fact, though, sometimes they actually give you different drugs of choice. And that means you will have to come down and figure out exactly what's going on. Evidence-based guidelines often will provide a drug of choice. The problem, of course, is that sometimes patients are allergic, sometimes it's very expensive, sometimes for whatever reason the patient can't take it. The other question, of course, that you have to ask yourself is something really an infection? Just because something is red and swollen doesn't mean it's an infection. Maybe the most common thing that I see with this is someone will have an insect bite and go to the emergency room 4 hours later, and they'll go, oh, it's red and swollen, it looks infected. Well, that's really too early for an infection to have developed in that area. So infection is not necessarily always the answer. Um, the redness might be from something else. The other thing, of course, is that you may have people that culture out organisms and have colonization, and really don't necessarily have a clinical infection. Clinical infection, by definition, is when the colonization or when the group of bacteria are causing problems for the organism. And the antibiotic stewardship people really would like us to try to avoid using antibiotics unless we absolutely need to. In fact, many people will be able to fight off bacterial infections by themselves, and you don't always need to jump to an antibiotic. Places that you can affect an infection, you can look at the agent. So what is the organism? How can it be killed? What are the factors that we can do to get rid of it? What's the route? Can we avoid it by wearing gloves, by having better hygiene as far as catheterization, those kinds of things? And also other host factors that we can look at. Can the patient's nutritional status be improved? So one of the things that you really do need to spend a fair amount of time doing is really understanding the various types of organisms, the types of bacteria, mostly the gram-positives and gram-negatives. Anaerobes and aerobes are somewhat important, and when you're dealing with a GI infection, you do need to think about anaerobes, but unfortunately anaerobes are really hard to test for. Mycoplasma are sort of halfway between a bacteria and a virus, so you really need to understand what those are. They don't have a cell wall, so you really cannot use a bacterial approach, antibiotic approach, which involves cell wall synthesis. So the penicillins or the cephalosporins won't work on mycoplasma or chlamydia. Those are often referred to as atypical bacteria. Viruses, of course, are something different. They are obligate within the cell, and there's very specific medications that we use to kill viruses. Rickettsia are becoming a bit more common. Things like Rocky Mountain spotted fever, those kinds of things are being passed more often. Parasites, which are protozoal infections, such as Giardia, those kinds of things require certain medications. And fungal infections are often treated topically, but there are times we will use systemic approaches, including situations such as toenail fungus. So just to go back to bacteria, they're usually either gram-positive or gram-negative. They're usually shaped either round, which is cocci, rod-shaped, which is bacilli, or spirochetes. Aerobes are much easier to culture out. Those are the ones we're usually going to be dealing with. We will cover empirically. Empirically is a word that just means based on previous research. We will cover empirically for anaerobes for many GI infections. So the most common gram-positive cocci are going to be staph and strep. And so staph occurs in clusters. Staph aureus is the most common one that we're familiar with. Most staph is methicillin sensitive, sometimes called MSSA. Methicillin resistant staph is getting more common, not crazy hard to treat with the strains that we're usually dealing with, which are the 300 and 400 strains. But you do need to keep in mind that they do require a different antibiotic approach. Coag negative staphs, such as saprophyticus or epidermidis, used to be thought of as contaminants. We do know now that they can cause infections in joints and some other places, but when they culture out, you do need to decide whether it represents some contamination or an actual infection. Gram-positive cocci, which occur in chains or strep. If it's just two, that's a diplococcus. That can be something like strep pneumo, which is a very common respiratory infection. That's the most common alpha hemolytic strep. Beta hemolytic streps, the most common are group A beta hemolytic strep, strep pyogenes, which is the organism which causes strep throat. Group B strep is not usually a pathogen, but can be in babies. Group C strep usually causes the pharyngitis, sometimes very similar to the group A strep. These are often the people that have tested negative for group A strep, but have the fever and other symptoms. They will respond to antibiotics since it is a bacteria, but they also will get better on their own usually, and it does not turn into rheumatic fever or the glomerulonephritis that can happen with group A beta hemolytic strep infections. Group D strep is enterococcus. That is not usually referred to as group D strep. It's usually referred to as enterococcus. Group F and group G. Group G can be group A and group C like, but generally we don't even hear these reported out. Gram-positive rods, Clostridia and Listeria are gram-positive rods. You almost never hear these reported out. Most people, when these kinds of things are reported out, go running for their computer so that they can look them up. Gram-negative rods, bacilli, these are very common enteric type bacteria. They cause things like urinary tract infections, but can also cause other infections. Require usually a different type of antibiotic than the gram-positive rods. But if you know what kinds of antibiotics are usually needed for things, you can get a sense of what the usual organisms are that you're trying to kill, and vice versa. So if you knew that you're trying to cover for a certain organism, you can look up to see what bacteria will cover that in the setting or in the site where you're looking at it. You have to remember that not all antibiotics will have good penetration to every site. Gram-negative coccobacilli. So these are actually bacilli that are a little bit shorter, a little bit more rounded, often just referred to as bacilli, but remembering that H-flu and Bordetella pertussis and Legionella and Pasteurella multicida often are a little bit different in shape, and you may actually be able to try to figure out what the organism is based on that gram stain. Gram-negative cocci usually send people running for Cipro. When one has gram-negative cocci, the most common thing that we're going to see is Neisseria meningitidis, also known as meningococcus. And in that case, if you have had intimate or close exposure, you will need prophylaxis, although that usually just is just a single Cipro. Gonorrhea, we rarely see reported out this way. Gonorrhea is usually tested with a PCR type test. Spirochetes, two most common. Syphilis has been around for a very long time. We definitely still see occasional cases of syphilis, but more commonly you're going to hear Borrelia talked about. The characteristics of spirochetes is they are hard to culture out, they are hard to find, and this is one of the characteristics that some of the folks that believe in chronic Lyme have pointed out in relation to Borrelia. The treatment for Borrelia is usually doxycycline. You can't use a first-generation cephalosporin. Amoxicillin is also an alternative treatment, and this is what we use in kids because you can't use doxycycline in someone under age 8 because it'll discolor the teeth. Whether or not chronic Lyme exists, we'll leave for another discussion. The Infectious Disease Society says that once you've treated somebody, they do not have a chronic infection, but that they may have chronic damage from the Lyme. They actually call that PTLDS, or post-treatment Lyme disease syndrome. So Mycobacteria, as noted, previously we had talked about mycoplasma, so you have to be careful not to get the two confused. Mycoplasma are sort of halfway between a bacteria and a virus. Mycobacteria are actually kind of halfway between a bacteria and a fungus. So they usually are more fungus-like. They have a thicker cell wall. The most common example is Mycobacterium tuberculosis. And it usually requires either triple or even quadruple drug therapy to be effective, just because it is very hard to get through that really thick cell wall. Fungal infections, we'll talk more about the specific medications we use for fungi or yeast, but fungus is basically all over the place. Any place that's warm, dark, and moist, you're probably going to find fungus. And so sometimes you can get rid of a fungal infection by just getting rid of that. Open it up to the air, get some light exposed to it. But there are definitely certain antifungal medications that we can use. And when one has an infection, I have a long involved explanation on the YouTube channel that is addressing labs and diagnostics. But just to talk a little bit about the white blood count, the white blood count will usually be elevated in most bacterial infections, but in viral and non-bacterial infections, it actually may go down. The differential, the segs and bands are types of neutrophils. Those are elevated in a bacterial infection. Lymphocytes are elevated in usually viral infections. Monocytes are elevated in late bacterial infection and some cancers. Eosinophils are elevated in worms and wheezes and weird diseases, and so allergies or parasites. There's another type of white blood cell, the basophil. We rarely will see basophils. The normal is 0 to 1. Anytime you have an elevated basophil count, we're a little bit more worried about a cancer. So we really didn't include it in this discussion of the differential. When you have people who have more of an immune response, antigen-antibody reaction, such as you would see in a viral infection, then you're going to look at things like IgMs and IgGs, but again, we'll discuss those down the road, and there is more discussion of those in the discussion in the labs and diagnostics course. This ends section 1. There's at least 2 more sections to go.